So today we are looking at visual fields printouts and the interpretation as well. So please, I would love you to listen attentively as we proceed. So I know you'll be wondering what visual field actually means. So visual field is the total area in which objects can be seen in the peripheral vision while the eye is focused on a central point. While looking straight ahead, of course, you can perceive things by the side, even though you're not seeing them clearly. So visual field simply means the totality of vision one can actually perceive while looking straight ahead. So it is the area seen by the eye and, of course, processed by the brain. So the visual field has about two components, the central vision and, of course, the peripheral vision. So let's just briefly look at the anatomy of the visual field. So this includes 1, the central vision, 2, the peripheral vision, like I mentioned earlier. It also has the optic disc, the macula, the fovea, the optic radiation, and of course the visual cortex. So the central vision is the area directly in front of the eye, which is responsible for sharp and detailed vision. The peripheral vision is the outer area detecting motion and changes, of course, by the side, like I mentioned earlier. Then the optic disc is actually the blind spot where the optic nerve enters the eye. The macula is the central region responsible for sharp vision, and the fovea is a small pit in the macula for highest visual acuity. The optic radiation are nerve fibers transmitting visual information to the brain, and then the visual cortex is the brain area that actually interprets visual data divided into areas V1 to V6. Of course, you cannot talk about the visual field without talking about the visual pathway. In fact, there is no visual field without the visual pathway. So the visual pathway is the neural route that transmits visual information from the eye to the brain, processing and then interpreting visual data. The visual pathway is made up of the retina, the optic nerve, the optic chiasm, the optic tract, the lateral geniculate nucleus, LGN, the optic radiation, and then the visual cortex. So this is a picture of the visual pathway from the optic nerve, from the retina, the optic nerve, down to the visual cortex. So there are several types of tests for vision. Include the static perimetry. By perimetry, I mean visual field. We have the kinetic perimetry. We also have the automated perimetry. So for the static perimetry, the visual field is tested by presenting static light stimuli at different locations. So this static perimetry is actually done manually. We also have the kinetic perimetry, which is also done manually. Most of us have been exposed to some of the kinetic perimeters while in school, just like the Jerome chart, where you use a target, move it from the side, then inwards in order to be able to map out the visual field. So the kinetic perimetry tests with moving light stimuli to map out the visual field. Then the automated perimetry is the same thing as the static perimetry. The only difference is that the automated perimetry uses machines. So the automated perimetry uses automated machines, just like the Humphrey Visual Field Analyzer. We also have the Octopus. We also have so many of them. So there are certain indications for visual field testing. The things you will see that would make you refer a patient for visual field testing. So we have the eye conditions. We also have some neurological conditions. For the eye conditions, we have conditions like glaucoma, have conditions like retinal diseases, optic neuropathies. For neurological conditions, we have stroke, brain tumors, and then multiple sclerosis. There are some visual field defects. We'll just take some common visual field defects like scotoma, like hemianopsia, quadratanopsia. So for scotoma is actually an area of unseen within an area of seen. So it's an area of partial or complete loss of vision surrounded by a field of normal vision. So you can actually say it's an island of unseen surrounded by an island of seeing. So we have the hemianopsia, which is loss of half of the visual field. We also have the quadratonopsia, which is loss of 1/4 of the visual field. So this is what a scotoma looks like. You can see the area of unseen, the blur part, surrounded by the island of seeing, that is the clear part. So this is what a scotoma actually looks like. So this is what a hemianopsia looks like, loss of half of the visual field. If you look at this image very well, you will see that half of the vision here is lost for this eye. Same thing for this eye. So hemianopsia is actually loss of half of visual field. This is quadratonopsia, loss of 1/4 of the visual field. So there are certain conditions that can actually cause this quadratonopsia, especially lesions in the visual cortex. For the hemianopsia, you have lesions in the optic chiasma. So as an optometrist, you should prioritize visual field testing, especially when patients come down with glaucoma, when they come down with retinopathies, when they come down with neurological conditions, and then you want to actually ascertain their level of vision comprehensively beyond the visual acuity testing. So we are going to look at procedures used in evaluating the visual field printout. But before then, we are going to take a look at some visual field analyzers, the ones we use in our various clinics, in our various training institutions. So this is a Humphrey visual field analyzer. It has different makes depending on the manufacturer. This is also an Octopus visual field analyzer. This is an Octopus 300 visual field analyzer. This is a Hansen visual field analyzer. This is Hansen as well. This is Hansen as well. This is Hansen. This is Oculus. This is Oculus. This is Oculus. And so on and so forth. So we are going to take a look at the printout, how it looks, and then the components as well. So for a visual field result printout, there are so many components you should look out for. We have the reliability indices, we have the grayscale, we have the numerical data, we have the total deviation map, we have the pattern deviation map, we have the global indices, we have the mean deviation, we have the pattern deviation, we have the visual field index. So we're going to take them one after the other. So for the reliability indices, some authors call it the catch trials. So before you even think of interpreting a visual field result, you should first of all look at the reliability indices for you to be able to know if you are supposed to go ahead with the interpretation or maybe resend for another test. So the fixation loss, the false positive, the false negative are all part of the reliability indices. So once you get a visual field result, you are supposed to look at these reliability indices, check if any of them is more than 33%. Some authors will tell you more than 25%, please do not interpret. Some other authors will tell you more than 33%, please do not interpret. So you also look at the grayscale plot, which represents the sensitivity of the visual field, using dark areas to indicate regions of low sensitivity. You also have the numerical data plot. Some authors call it the sensitivity plot, which shows the numerical sensitivity values for each tested location. You also have the total deviation map, which shows areas where the patient's performance deviates from the normal. Of course, you should know that the machine actually has predetermined information, predetermined values gotten from millions of people within a particular age range. Okay, so while doing the test, the machine actually compares the person's sensitivity to the sensitivity of that person's age bracket in order to get the deviation, which we call the total deviation. So it shows us the areas where the patient's performance deviates from the normal, depending on that patient's age bracket. and then the data available for that particular age bracket. So we also have the pattern deviation map, which actually highlights the localized defects by removing generalized depressions. So this pattern deviation shows us the exact defect. Some authors will tell you that it compensates for the total deviation. So we also have the global indices, which shows us the mean deviation and the pattern deviation as well. So the mean deviation shows us the average deviation of the field from normal. And then the pattern deviation measures the localized field length. So the visual field index actually shows us the overall field function of the patient being tested. So look at what the printout looks like. So this is a Humphrey visual field. So all those things I listed, we are going to take them one after the other. So this is what the visual field printout looks like for that of Humphrey. So if you get the visual field results, you look at the patient's demographic data, you look at the age, you look at the patient's prescription for some patients who have who wear high-powered lenses. You know, sometimes you may need to actually give them their lens equivalent for them to be able to appreciate the visual field testing. So you look at the pupil size. You now go over to the reliability indices, which we'll call the cash trials as well. So you have the fixation loss, you have the false positive, you have the false negative. Like I told us earlier, if you get a visual field printout and you want to interpret, you should first of all check the reliability indices or the cash trials. Check the percentage there. If it is more than 33%, please do not interpret. To be on a safer side, if it is more than 25%, please do not interpret. You can always send the patient back for a second testing. So we also have the method, the strategy, and the test duration. We have the results, okay? So if you look at the printout very well, you will see the total deviation, you see the grayscale, you see the pattern deviation, and then you see the probability plot as well. So we'll take them one after the other. Please try to follow my arrow. So here is called the grayscale. It's called the grayscale. So it uses dark patches to represent depressions. So here is the grayscale, and here is the sensitivity plot, or what we call the numerical data. Like I told us earlier, that the machine already has predetermined values gotten from millions of people. So while doing the test, the machine compares the patient's sensitivities at different retinal points to sensitivities at different retinal points of millions of people within that age bracket. So if the machine does the comparison, it will now give us the numerical data by giving it. It can come in plus sign, it can also come in minus sign, but then the machine doesn't show plus signs. It can only show you figures. You will know that this figure is either a plus or a minus. But then if it's a minus sign, it will show, but it doesn't show us plus sign. So for figures that do not have minus signs, you should know they have plus signs. So it actually means that for that particular point, the patient is seeing better than his or her age bracket is seeing. If you see a minus sign, it means that the patient is actually seeing lesser than his or her age bracket. So here is the numerical data or the sensitivity plot. Here is the total deviation. Here is the total deviation. And then here is the pattern deviation. So for the total deviation, the machine shows us areas where the patient is having deficits or where the patient is seeing better. Then the pattern deviation shows us the actual areas where the patient is actually seeing better or worse. So some authors will tell you that the pattern deviation compensates for deficits seen in the total deviation. Some authors can give you a kind of illustration using a class test where everybody fails. So the lecturer might want to upgrade the student scores by giving 10 points bonus, to all the students in order to actually upgrade their scores. So for people who have low scores, their scores can be a bit augmented. So someone who has a -5, if you give the person a +10 bonus, the person will be upgraded to +5. For someone who already has 10, with the +10 bonus, the person will be upgraded to 20. So that's what the pattern deviation does. It compensates for deficits seen in the total deviation. Then we'll have the probability plots. So under the total deviation, we have the pattern deviation probability plots. So it uses symbols. It uses symbols to tell us about the depression seen in the total deviation. Same as the pattern deviation probability plots. It also uses symbols to tell us about the depression seen in the pattern deviation. Okay, so you can see the symbols here. This one looks like 4 dots. This one looks thicker, this one looks thicker, and this one looks very thick. So for the first one that looks like 4 dots, you can see less than 5% beside it. So this means that less than 5% of the population within that age bracket is having this depression. Less than 5% of the total population within that age bracket is having this defect. So you can actually say that the defect seen, if you see this kind of defect, you can actually say that it is not severe. The second one is less than 2% of the population is having this defect. So you can say that the second one is severe compared to the first one. Then the third one is showing us less than 1% of the total population within that particular age bracket. Of course, this is a worst case. And then the worst of them all is the last one, the last symbol, which is very, very thick. If you look at the last symbol, it is very thick. And it's showing us less than 0.5% of a particular population is having this defect. So this is very, very severe. So anywhere you see it in the total deviation probability plot or in the pattern deviation probability plot, you should know that the depression is severe, especially when it is all over the field. When you see it all over the field, you know that the depression is quite severe. So you can also see the glaucoma hemifield test by the right side of the printout. So the glaucoma hemifield test can either be within normal limits. It can be within normal limits, telling you that this person's visual field is still intact. It can be outside normal limits, telling you that this person is having severe depression. It can also be within the borderline. So if it's within the borderline, it means that the patient is actually between not having glaucoma and then having glaucoma. So these people who whose glaucoma hemifield tests are at borderline needs to be monitored. You have to follow them up. You have to always send them for the CVF to check the progression of the condition and then to check if the treatment regimen you're giving is actually effective or not. So also have the global indices comprised of the mean deviation and then the pattern deviation. So for the mean deviation, it has a range that tells you the type of depression the patient is having. So the mean deviation from +2 to -2 decibel tells you that this person is having a normal field. Mean deviation from -3 to -5 decibel is telling you that this patient is having mild damage. And then mean deviation of -6 to -8 decibel tells you that this person is having a moderate depression. And then mean deviation of -9 and above tells you that this person is having severe depression. And then for the pattern standard deviation, that's the PSD, the normal range is 0 to 2.5 decibel. And then if you are seeing from 2.6 to 3.5 decibel, there is mild depression. If you're seeing 3.6 to 5 decibel, there is moderate depression. And then any figure higher than 5.1 decibel, there is severe depression. So you also look at the visual field index. for some printouts, they will show you the visual field index, and some other printouts will not show you the visual field index. So if you look at the visual field index, the normal is from 100% to 95%. If there is a mild damage, you have 94% down to 85%. And then if there is a moderate damage, you have 84% down to 70%. And if there is a severe damage, you have 69% or less. So this is an Octopus printout, same as the Humphrey visual field printout. So for this Octopus printout, instead of showing us the sensitivity plot, it shows us instead of showing us the grayscale, it doesn't represent depressions with dark patches. Instead, it shows us numbers. So here is the same thing as our grayscale. If you look at it very well, then here shows us the values gotten from the patient. The values gotten from the patient, which we'll call the sensitivity plot. Then we also have the comparison. This comparison for Humphrey, it is called the total deviation. Then the corrected comparison here for Humphrey is called the pattern deviation. Then these are the probability plots. So this probability here for Humphrey, it is called the total deviation probability plot. And then the corrected probability is here for Humphrey, it is called the pattern deviation probability plot. So both of them are saying the same thing, just that they are using different terms. Then additionally for Octopus, Octopus includes a baby curve to actually tell you the type of depression seen. So here is the baby curve. Here is the baby curve. It actually comes with a shaded area. So the shaded area tells you the type of depression seen. So within the shaded area, a thick line runs through it. So if the thick line is parallel to the lines in the shaded area, if the thick line runs parallel to the line in the shaded area, so it is seen as normal. It is seen as normal. So if the thick line runs parallel and then gives us a sharp bend, if it runs parallel and then gives us a sharp bend, if it runs parallel and then gives us a sharp bend, it is known as localized depression. Then if this thick line runs outside the shaded area, but parallel to the lines in the shaded area, it is known as generalized depression. And then if the thick line runs outside the shaded area, parallel, and then to an extent gives us a sharp bend, it is known as localized and generalized depression. So that's for the Octopus visual field printout. So we'll look at the parts of the Humphrey visual field and then the parts of the Octopus visual field. You will find out that they are both showing the same thing. So for the Humphrey, we have the reliability indices. For Octopus, we also have the reliability indices. We have strategy used in Humphrey. We also have strategy used in Octopus. We have the grayscale. We also have the grayscale in Octopus. Like I told us earlier, for the Octopus, the grayscale doesn't use dark patches to show us depressions. Rather, it uses numbers. Then we have the numerical values for the Humphrey. We also have numerical values for the Octopus. We have total deviation for Humphrey. Then we have comparison plot for Octopus. We have pattern deviation for Humphrey. We have corrected comparison for Octopus. Then we'll have the glaucoma hemifield test. We'll have the defect curve. That is the baby curve, like I showed us earlier. We'll have the global indices for Humphrey. We'll also have the global indices for Octopus. So these are the printouts side by side. The first one is the Humphrey, and then the second one is the Octopus. So you can appreciate the grayscale. Here it's showing us figures, and then the Humphrey is showing us dark patches representing the depressions seen. So look at the sensitivity plots. Look at the sensitivity plots for Humphrey, and then you see values for Octopus. Then this is the total deviation for Humphrey. Here is the comparison for Octopus. This is the pattern deviation for Humphrey. Here is corrected comparison for Octopus. Here is total deviation probability plot. for Humphrey. Here is probabilities for Octopus. Here is pattern deviation probability plot for Humphrey. Here is corrected probabilities for Octopus. So we have the glaucoma hemifield test here for Humphrey. Then we'll have the defect curve, or what we call the Bebe curve for Octopus. So let's look at how to read the visual field report. So while reading the visual field reports, we'll look at Apostilbs, we'll also look at decibels. Okay, so in perimetry, the luminance of every target is measured in Apostilbs. So an Apostilb is an absolute unit of luminance. Luminance means brightness or intensity of light. Then this decibel scale is a relative scale created by the manufacturers of automated perimeters to measure the sensitivity of the island of vision. So a decibel is an inverted logarithm, scale. So by inverted logarithm scale, it means that the higher the Apostilb, the lower the decibel. By Apostilb, I mean the luminance, the intensity of light. So the higher the intensity of light, it means that the sensitivity of that particular area is low. Okay, so Apostilb represents intensity of light. Decibel represents the sensitivity of a particular retinal point. So anywhere around those results, be it the total deviation, wherever you see a high Apostilb, you will of course notice a low decibel. Wherever you see a high decibel, you will of course notice a high Apostilb. So the decibel is an inverted logarithm. So the higher the intensity of light shown, you know that while performing the test, the luminance of those targets are being graduated. Okay, they can start from low intensity to test a particular retinal point. If the patient is not seeing that low intensity of light, the machine graduates it to a higher intensity, a higher Apostilb. If the patient doesn't see it, the machine also graduates it to a higher Apostilb. So the higher the Apostilb, the lower the sensitivity of a particular retinal point. So look at what it looks like here. So we'll have the Apostilbs and we'll have the decibels. So if you look at the left corner, you will see 0.1 Apostilb. So this 0.1 Apostilb simply represents a very low intensity of light. Okay, then if you go over to the decibel, like I told us earlier, the lower the Apostilb, the higher the decibel. So the 0.1 Apostilb means a very low intensity of light, and then that particular retinal point captures it. So it means that that retinal point has high sensitivity. So we'll have 0.1 decibel, and we'll have 0.1 Apostilb, and then for the decibel, we'll have 50 decibel, which is showing us very high sensitivity. So we'll have 1,000 Apostilb. 1,000 Apostilb here means very high. And then, of course, the higher the Apostilb, so it means that the light was being graduated and graduated and graduated until the patient was able to capture it. So the higher the intensity of light shown or captured, the lower the sensitivity of that particular retinal point. Okay. So let's go straight to how to read a visual field printout. So we are going to be making use of the Wanda scheme or Wanda pattern of interpreting or reading a visual field report. So I know you'll be wondering what Wanda means. So the W in Wanda means what was done. The A means accuracy. The N means normal, or the D means defect pattern. The E means evaluation. The R means review or reflection. So we start with the W, what was done. So it's actually in two items. We have the A in the test. So for the area tested, we'll have the central 60, We also have the central 30. We also have 24. We also have the central 10. The central 30 and the central 24 are they are identical. They are only 6 degrees. So think of the central 10 as a tiny circle spreading out of the central vision up to 6 to 8 inches. Let me take that again. Think of the central 10 as a very tiny circle spreading out of the central vision up to 6 to 8 inches. And think of the central 24 as not as small as the central 10. Think of the central 30 and 24 as a small circle that is 30 degrees wide and then extending about 1 to 2 feet from the center of vision. Then think of the central 60 as a bigger circle extending up to 3 to 4 feet from the central vision. So we've talked about the area tested with the central 30, the central 24, and then the central 10. Talk about the strategy used. So this strategy used simply means a pattern used to present the stimuli and also the pattern used to graduate the luminance of the targets presented. So there are commonly used strategies and they include the full threshold strategy, the screening strategy, the fast test strategy, which includes the SITA fast, the SITA standard, and then these fast test strategies, they run very fast, just like the name implies, and they last less than 5 minutes. Each of them lasts less than 5 minutes, while the full threshold strategy and the screening strategies can last quite longer. So we'll take the area tested, the central 10 and the central 24. Like I said earlier, they are both identical and they are 6 degrees apart. So for the central 24, unlike the central 30, the central 24 has its outer ring omitted. So the central 24 has its outer ring omitted. I will show you what it looks like. And then it is 29% fewer. That's the points tested is actually 29% fewer than that of the central 30. But they are identical and they are only 6 degrees apart. So if you're using the central 24, you are trying to shorten the time of the test. In this case, reducing the patient's fatigue and then avoiding lack of attention or interest. So look at what the central 30 looks like. You can see the points tested. And then, like I said earlier, for the central 24, the outer ring is being omitted. So look at the central omitted. Look, outer ring is there. The outer ring is being omitted. The central 30 looks like, and then the central 24 as well. So for the central 30, it has all of its rings intact. Then the central 24 has the outer ring being omitted. So the central 30 tests about 76 locations, while the central 24 tests about 54 locations, making the test duration shorter. Then the central 10 tests so many close locations as the central region, and then it therefore gives us a better resolution with better information with respect to the macula. So it tests about the rings being tested in the central 10 is 2 degrees apart. So each particular point or each particular ring is 2 degrees apart from the next. So it is better for follow-up visits, especially for patients who are having macular problems. And then it tests about 68 locations. So it gives us a better information with respect to the macula. So for the central 30, tests about 76 locations. The central 24 tests about 54 locations. And then the central 10 tests about 68 locations. And then the grids being tested, the grids means the circles being tested in the central 30 is about 6. That of the 24 is about 6, while that of central 10 is about two grids, that's two circles within the macula. So I know you're seeing the central 10 to central 24 to central 32. So the first number, which is the 30 or the 10, actually represents the degree of the field tested. Then the second number, which is the 2, it can also be 1, shows us the testing protocol. So for the test strategy, like I said earlier, it's actually a method used to determine the differential light sensitivity. So it is a pattern the machine uses to graduate the intensity of the light shown at different retinal points. So in the normal test strategy, stimulus luminance or brightness is actually varied up and down in steps. Some machines use staircasing or bracketing strategies. So we talked about the full threshold. So the full threshold has a standard which makes use of 4-2 staircasing. It also has a fast pack which makes use of 3 decibel staircasing. So for the 4-2 staircasing or bracketing, this simply means that when the test is started, the machine projects a particular light of a particular intensity to a particular retinal point. If that retinal point captures the stimulus presented, the machine reduces the intensity by 4. If the retinal point still captures it, it now reduces it by 2. So that is what it means by 4-2 staircasing. So at any point, the machine projects the stimulus and the patient and that retinal point does not see the stimulus presented. The machine increases. Instead of reducing, the machine increases by 4 decibels. If the retinal presented, the machine will also increase by 2 decibels. So that's all about the 4-2 staircasing. While the fast pack, which is 3 decibels, the machine either goes 3 decibels up or 3 decibels down, depending on if the retinal point actually captures the stimulus presented or not. So also have the fast threshold, like the SITA, the TOP, the ZATA. So the TOP simply means threshold per octant pattern. The ZATA means zest algorithm threshold analysis. The SITA means Swedish interactive threshold algorithm. They also have the screening strategy, which shows us 2-zone screening and also the 3-zone screening. Then we'll have the SWAP, the short wavelength automated perimetry. So this particular strategy actually tests the low wavelength cones in the retina. So it is quite fast and then is more reliable in knowing the integrity of the macula. Okay, let's proceed. Thank you so much. I was talking about the W in the WANDA scheme. So the W simply means what was done. So you talk about the area tested and the strategy used. So the area tested includes the central 10, the central 30 or central 24, which are identical. And then we also have the central 60. As I was saying earlier, the central 10, you can think of it as a very tiny circle spreading out of the central vision up to 6 to 8 inches. That's from the central vision. Then the central 24 or the central 30, they are identical actually, just that they are only 6 degrees apart. So the central 30 or the central 24, you can think of it as a bigger circle, quite bigger than the central 10, extending about 1 to 2 feet from the center of vision. And then the central 60, which is the largest, is a very big circle extending about 3 to 4 feet from the center of vision. Okay. So there are certain strategies used while performing the visual field testing. We have the full threshold, we have the fast pack, we have the swap, short wavelength algorithm threshold. We also have the SITA, which is the fast threshold. So for the fast threshold, the test lasts less than 5 minutes compared to the other strategies used, like the full threshold, which can last up to 20 minutes, because the full threshold actually tests a particular location up to 5 times. So it can test a particular location up to 5 times by graduating the luminance up or down until the patient is able to actually capture the stimulus presented. So let's go over to the A, which is accuracy. So if you're interpreting a visual field results, like I said earlier, you should first of all look at the reliability index, which we also call the catch trials. So the reliability index is made up of the false positive, the false negative, and the fixation losses. So this will actually help you check whether the test is reliable or not, and whether you are going to continue with the interpretation or send for retesting. So we'll have the fixation loss, we'll have the false positive, we'll have the false negative, we also have the short-term fluctuation. So for Humphrey, the fixation loss, the false positive, the false negative should not be less than, should not be more than 33%. So it should actually be less than 33% before you proceed with the interpretation. But to be on a safer side, all the components of the reliability index should be less than 25%. All of them, to be on a safe side, so all of them should be less than 25%. So let's talk about the fixation loss. So for the fixation loss, if a stimulus is thrown at a particular location, for example, the blind spot, where of course the patient should not see, and then the patient tells you that he or she is seeing it, by clicking, especially for trigger happy patients, and then the location is tested and then retested, and the patient is clicking. So it means that the patient has actually lost fixation, or the patient has actually lost focus. Okay, because of course for the blind spots, vision doesn't happen there. So any stimulus thrown at the blind spot should not be seen. So if the blind spot stimulus is repeated up to 20 times, and then the patient reports seeing it up to 3 times, that means the fixation loss will be printed as 3/20, because the patient has actually lost fixation, and then you're presenting a stimulus to the blind spot and the patient is still clicking, telling you that he or she is seeing. So it will be recorded as 3/20. Then you can get the percentage of 3/20 to know if the percentage is less or more than 33%, or to be on a safe side, if it is more or less than 25%. So the machine also uses a system with which it monitors the focus of the eye of the patient. So at any point the eye moves away from the fixation target, the machine also records it as fixation loss. So the machine has all these capabilities in it. So if the eye moves away from the fixation target, the machine captures it as a fixation loss and also records it. So we have the false positive. False positive simply means a stimulus is not thrown and then the patient is clicking, telling you that he or she is seeing. So sometimes instead of presenting light stimulus, the machine can actually give sounds. You know that the sounds come with the stimuli. So the machine can present the sound without the stimulus, and then the patient is busy clicking. So it's recorded as false positive. So the false positive result occurs if the patient responds to the sound alone. Then the false negative, sometimes a stimulus will be presented or projected, and then the patient sees it the first time. So when that particular location is tested a second time and then the patient is not clicking, the machine records it as false negative, because if the patient has seen it the first time, it is expected that the patient should also see it the second time and even the third time, depending on the strategy used. So for the false negative, no response at a location that had earlier been examined and then responded to, just like I said earlier. So high false negative indicates that the patient is inattentive and then the result is unreliable. So if it is more than 25%, that means the result is unreliable. So any of the cash trials that is more than 25% for some authors or more than 33% for some authors, we don't bother interpreting. So also have the short-term fluctuation. So for the short-term fluctuation in static perimetry, repeated threshold measurements at a single location vary and cause a fluctuation of threshold responses. So the stimulus, the luminance of the stimulus is being graduated. So varying the responses given by the patient. So in normal visual field, the short-term fluctuation should be between 1 and 2 decibels. So short-term fluctuation that is more than 2 decibels may indicate poor reliability. So if you check the short-term fluctuation and it is more than 2, you may not proceed with the interpretation. So we'll go over to the N, which is normal or abnormal field. Okay. So the next question you should ask yourself is the field normal or abnormal? So to answer the question, we'll look at the gray scale, we'll look at the numerical values, we'll look at the total deviation, we'll look at the pattern deviation, and of course, their probability plots. So like I said earlier, the gray scales, actually represents the depressions using dark patches. So the gray scale gives us a reasonable impression at a glance about the field. But of course, you should not depend on the gray scale. You should also look at other parts of the result, the pattern deviation, and then their probability plots. So I've shown us this before, how the gray scale looks. So this is the gray scale. It uses dark patches to represent the field. So we've talked about the numerical values. Some authors will call it the sensitivity plot. So these are the numbers that represent the sensitivity of the retina for each patient. Okay. Then the total deviation compares those values gotten to the values of patients or people within a particular age bracket. Like I told us earlier, the machine has predetermined values gotten from millions of people within a particular age range. So the machine compares the values gotten from a patient being tested to the predetermined values in order to get the deviation. So it can either be higher or lesser, if a patient is having deficit compared to people within that particular age range. So for example, if the sensitivity of a patient's retinal point is 26 decibel, and then the normal for his age bracket at that same point is supposed to be 30, the difference is minus 4 decibel. So this is the total deviation. So again, if the sensitivity of a patient's retinal point is 26 decibel, and the normal for his age bracket at that same point is supposed to be 24. So the difference is plus 2. So here you can see that it is higher. So the patient is seeing better than his age bracket. So look at the information stored by the computer, the predetermined values gotten from people of a particular age bracket. Okay. So you can see the numbers for every retinal point for a particular age bracket. And then this is for a patient that is being tested. So at this retinal point, for the patient that is being tested, we are having 23 decibel. Then for his age bracket, for that retinal point, we are having 24. So if we are going to the total deviation, for this particular retinal point, you are going to have minus 1 here. Let's check another retinal point. We'll have 10 here, gotten from the patient being tested. Then for the same retinal point, for that particular age bracket, we are having 20 here. So if you go over to the total deviation, at this particular retinal point, we are going to have minus 10. So you can see it here. Here we are having -10 for that retinal point because the age bracket, the normal here should be 20, while the patient is having 10. So if you subtract 20 from 10, you're going to have a -10. So that's how the computer compares the values gotten from the patient based on the respective retinal points to values based on the same retinal points gotten from people of the same age. Then the machine can now represent the deviations on a grayscale using patches to represent areas of depression. So we talked about the pattern deviation earlier, which is the difference between the adjusted threshold of each individual test location and the age-corrected normal value for that location. So the pattern deviation gives us the exact depression. It gives us the exact depression within the field. So it identifies areas of the field that are actually abnormal and then compared with age-matched normal population for each point tested. So like I said earlier, the pattern deviation plots highlights localized defects by correcting for diffuse changes in the field of vision. So for example, in a class, a lecturer gives a test and a good number of the students fail or get to have very low scores. The lecturer can decide to add marks across border, like up to 10 marks, in order to be able to increase their scores, their overall scores. So for people who have, let's say, 10 out of 50, if the patient asks 10 marks to everyone, people who have 10 will now go over to 20. People who have 30 will go over to 40, just like that. So the pattern deviation compensates the deficits seen in the total deviation. So let's look at this example. Let's look at the figures in group A and then those of group B. So we'll have 95 here, we'll have 20 here, we'll have 92, we'll have 18, 90, 18, and so on. So the machine checks the 85% location and then does some subtraction there. So at the 85% location, the normal should be 94. And then the group A is representing the normal, of course, and then the group B is representing the sensitivity of the patient. So at the 85% location, the machine subtracts the abnormal from the normal. So we'll have 94 subtracted by 19 to give us 75%. So the machine will now add across border some points. So look at the adjusted results now. So we'll have 75 gotten, and then the machine adds up to 20 to it to give us 95. And then for every particular point, the machine can also add 20 to all the retinal points to increase the score points gotten for every retinal point. So the pattern deviation compensates for the deficits seen in the total deviation. So these are the compensations seen. The pattern deviation compensating the deficits seen in the total deviation. So let's look at the probability plots. Okay, let's look at the probability plots. This is the total deviation, and then here is the pattern deviation. Here is the total deviation probability plot. Here is the pattern deviation probability plot. Okay. So for the total deviation probability plot, you have some dark patches representing the depression seen in the total deviation. Then in the pattern deviation probability plots, you also have dark patches representing the depression seen in the pattern deviation. So if you look at the total deviation probability plot, you can see that the dark patches are more here in the total deviation probability plot. And if you look at the pattern deviation probability plot, it looks lesser because some of the deficits have been compensated for. So that's what the machine does. So for the pattern deviation, the machine adds points across border in order to increase the points seen and make the charts better or make the visual field results better. So the probability plots for both the total and pattern deviation maps indicate the statistical significance of the deviation for each point tested. And then the probability plots are represented by shades and of course symbols. The darker the symbol, the less likely it is that a point depressed by that amount would occur in a normal population. When we started, I showed us the symbols that represent less than 5% of the population, symbols that represent less than 2% of the population, symbols that represent less than 0.1% of the population, and then symbols that represent less than 0.05% of the population. Then the baby curve or the defect curve, is a curve that shows us the graphic ranking of the defects for each point in the visual field. So the baby curves are actually useful in detecting diffuse depression of the visual field. I showed us the baby curve earlier. So the baby curve has a shaded portion. So within the shaded portion, a thick line runs through it. So if the thick line runs parallel to the lines in the baby curve, if it runs parallel to the lines in the baby curve and it is still within the shaded portion, the field is seen as normal. Then if the thick line runs from the shaded portion and runs parallel to a particular point and then gives us a sharp bend downwards, it is seen as a localized depression. Then if the thick line runs outside the shaded portion but parallel to the lines in the shaded portion, it is known as generalized depression. Then if the thick line runs outside the shaded portion and runs parallel to a particular point and then gives us a sharp bend downward, it is known as localized and a generalized depression. So look at what the baby curve looks like. This is what the baby curve looks like. So here, these first three lines are usually shaded, okay? Then look at the thick line I mentioned. So the thick line runs parallel to the lines within the shaded portion. So this is a generalized depression. If you see this kind of baby curve, and then you're seeing the thick line run parallel to the lines in the shaded portion. So this is a generalized depression. Then you look at these as well. Look at the shaded portion I mentioned earlier, and then look at the thick line running parallel to the lines within the shaded portion. So this is a normal field. So this is a localized depression because the thick line runs parallel to the lines in the shaded portion and then gives us a sharp bend downward. So this is a localized depression. And then we have a localized and generalized depression. The thick line runs outside the shaded portion, runs parallel to an extent, and then gives us a sharp bend. So this is a localized and generalized depression. So here we have a generalized depression, localized and generalized depression. So for the mean deviation, like we mentioned earlier, so the mean deviation is actually a measure of the average deviation between the patient's sensitivity and that of the age-matched normal. And the mean deviation is simply the average of the deviation values for all locations tested. So it gives us a sense of the overall height of the hill of vision. So we talked about the range for the mean deviation. So it actually ranges from +2 decibel to -30 decibel. So it actually has a range and then there are meanings. So for mean deviation between +2 decibel and -2 decibel, it is seen as normal. Then if you see a mean deviation that is from -3 decibel to -5 decibel, there is mild damage or mild depression. The mean deviations from -6 decibel to -8 decibel is seen as moderate damage or moderate depression. A mean deviation of -9 decibel and above is seen as severe damage or severe depression. So also have the pattern standard deviation. So the pattern standard deviation is a measure that reflects the shape or smoothness of the hill of vision. So it also has a range for the pattern standard deviation. The normal is from 0 to 2.5 decibel. Then if there is a mild depression or a mild damage, you have 2.6 to 3.5 decibel. Then if there is a moderate damage or moderate depression, you have 3.6 to 5 decibel. And then if there is severe damage or severe depression, you have 5.1 and above. So we've talked about this. So let's go over to the D. D means defect. So you check the fields and know the type of defects seen. So the next is to decide the pattern of the defects. So here we'll try to find out whether the pattern of the field goes with any particular disease. So you ask yourself if it is a neurological condition, if it is a retinal defect, for example, glaucoma. Of course, you should note that neurological defects respect the vertical raphe, or what we call the vertical meridian, while glaucomatous defects respect the horizontal raphe or the horizontal meridian. Okay, so for the glaucoma visual field defects, we have paracentral scotoma, we have aqueous scotoma, we have nasal step, we have attitudinal defect, we have temporal island or wedge, we have generalized depression. So these are defects you will see on the visual field printout while doing your interpretation. So if you look at this is an example of a paracentral scotoma. So just like we said earlier, a scotoma is an area of unseen within an island of seen. So if you look at this map, the whole of the white area is an island of seen, while the dark part is the area of unseen, which is where the scotoma lies. So this is a paracentral scotoma. Paracentral scotoma. So it is sparing the central part of the visual field, okay, and then it is outside the central part of the visual field. So if you see a defect that is like this, if you check the visual field, so this defect now on your visual field printout, it is not represented as a thick dark shade like this. It is represented by those symbols. So it is now left for you to join the symbols together to know the shape of the defect. So you join the symbols, you link them up and connect them to know the shape of the defect. That will help you to know the type of defect, whether it is paracentral or not. So this is example of altitudinal defects. Altitudinal defects. Okay. These are examples of altitudinal defects. So if you look at your visual field printouts, you connect those symbols for you to be able to know the shape of the defects, and then of course the type of defect, whether it is paracentral scotoma or whether it is an altitudinal visual field defect. So there are sources of errors while performing the visual field testing. Okay, so meiosis, we have lens opacities, we have uncorrected refractive error, we have spectacle lens artifacts, we have ptosis, and then we have inadequate adaptation. So for the E represents evaluation. So you have to evaluate your results. Okay. So evaluating the visual field results involves determining whether the field is normal or if any progression or improvement has occurred between two or more fields. So assessing test results begins with determining the reliability of the test. We've talked about the reliability earlier. So after understanding the defect pattern, noting if it is a paracentral scotoma or attitudinal defect. Okay, so the next is to evaluate the disease. You ask yourself if there is a field defect, if the defect is due to glaucoma or neurology, or if it is as a result of cataract or any artifact. Okay, then you ask yourself if you can accept the test results as valid after checking your reliability indices, that is the catch trials, the false positive, the false negative, the fixation losses, and the short-term fluctuations. Then you go over to R, which is review or reflect. Okay. So if you are doing your review or your reflection, so you ask yourself whether you need to repeat the examination, whether you have to continue to reflect on the test done, whether you're going to proceed with the interpretation or not. Please note that you should never make a diagnosis based on the visual field result alone. So you have to always correlate with other clinical findings like your fundoscopy, your tonometry, and even your OCT. So please look at the clinical peers. If the visual field is unreliable, please repeat the test on the same day or you rebook for another day. Then comparison of the results of the same patient at intervals can be used to assess the progress of the disease. Like I mentioned earlier, so you have to always send your patient for the CVF test so you can be able to um, check if the treatment regimen you're giving is actually good or not. So you have to always compare the progression of the disease, and the only way to note the progression of the disease is by sending for CVF, at interval. So selection of the program for each case is essential, and of course requires reading the instruction manual of the machine, and then the visual field test is of course a diagnostic tool that should be used with other clinical data to reach a diagnosis. So you don't have to depend on the visual field results alone. You have to always correlate with other clinical findings. Your fundoscopy, very important, your tonometry, your OCT, and any other clinical finding that would, of course, guide your diagnosis. So you can also do a field on a dilated or non-dilated patient, but you cannot do a field while the patient is dilating. So if you want to do the field on a dilated eye, you have to wait for some time till the eye is fully dilated before you can proceed with the test. If you don't want to dilate at all, you can then proceed with the non-dilated eye. So it may take up to 4 to 6 years before ganglion cell damage will be detectable on conventional visual field. Okay. Then understanding your perimetric machine is also essential as normal range values vary. Okay, just like I told us earlier. So for some machines, the Octopus and the Humphrey, some authors will tell you that for Humphrey, um, catch trials greater than 33%, you should not interpret. Then for Oculus, they will tell you catch trials greater than 25%, you should not interpret. So you have to understand your perimetric machine, because normal values or normal range of values may vary. Then you never make a diagnosis based on the visual field result alone. I've said this before, you have to always correlate with other clinical findings. So here is our conclusion. The visual field interpretation is an art which improves the experience. And of course, the testing of the visual field is fully automated, but unfortunately, the interpretation is not, at least for now. So the result has to be interpreted by an ophthalmologist or an optometrist. Therefore, visual field printout interpretation is an art that every optometrist must learn. So you have to learn how to make the interpretation, and you have to learn how to be accurate with your interpretation. So if you embrace the wonder scheme, it will make it easier for you. Once you get the visual field result printout, you make use of the wonder scheme. You ask yourself what was done by checking the areas tested and the strategy used. You check the accuracy, which involves checking the catch trials to know if you are going to proceed with the interpretation or not. You check the fields, whether they are normal or abnormal. You check the defects. You check the shape of the defect, the type of defect that is present. You do your evaluation, and then, of course, you do your reflection. So, informed and accurate interpretation of the visual field depends solely on careful consideration of all the information on the visual field printouts, and should, of course, should take into account other clinical findings, like I mentioned earlier. So no portion should be. So you cannot make your diagnosis just with your fundoscopy. You cannot make your diagnosis just with the visual field result printout. You cannot make your diagnosis based on tonometry alone. So you have to always correlate with other clinical findings. So that brings us to the end of the webinar. We look forward to having your questions and, of course, answering your questions. Thank you so much.
Thank you so much. So now we'll be taking questions. We've answered the first question in the chat box. So we'll be attending to the second question, which is from Scholar Hamilton Kiza. So he's asking, what are CAT trials?